and welcome to the AI for Good webinar series. My name is Ida DeBeer from the ITU, the International Telecommunication Union, and I have the privilege of introducing today's webinar. ITU is a United Nations specialized agency for ICTs, and we are also the organizers of AI for Good, in partnership with 38 UN sister agencies and co-convened with Switzerland. The goal of AI for Good is to identify practical applications of AI to advance the Sustainable Development Goals and scale those solutions for global impact. We are pleased today to discuss AI for healthy minds and healthy brains. We have a distinguished set of panelists today, but as always, we are counting on you, the participants, to help make this an engaging discussion. For this, we will be using the Q&A and the chat functionalities, which you can find at the bottom of your screen. You can also share about this session on social media by tagging at Monash DFI and using the hashtag Monash AI for Good. We will also be posting these in the chat. So without further ado, I would like to welcome our moderator today, Jane Fisher. Jane is Finkel Professor of Global Health, Director of Global and Women's Health in the Faculty of Medicine, Nursing, and Health Sciences at Monash University. She is also a clinical psychologist and was appointed Officer in the Order of Australia in 2019 for her contributions to perinatal mental health, women, and the community. Over to you, Jane.
Thank you so much for this opportunity and for the meticulous arrangements that have gone into preparing this webinar. I want to wish good morning, good afternoon, good evening to all of you who are joining us from many parts of the world. It's an Australian practice to pay our respects to the traditional owners of the unceded lands on which we live and work. But today I want to extend that and to pay my respects on our behalf to all First Nations peoples participating in this AI for Healthy Minds and Healthy Brains webinar. Mental health concerns us all. The World Health Organization reminds us in its definition that mental health is much more than the absence of illness. It's a state of well-being in which each individual is able to realize their abilities, cope with the normal stresses of life, work productively, and make a contribution to the community. And globally, mental health is recognised as a key factor in achieving a sustainable future. In the UN's Sustainable Development Agenda, Sustainable Development Goal 3 is about ensuring healthy lives and well-being for all at all ages. But we know that mental, neurological, and substance use disorders are among the leading causes of morbidity and mortality worldwide. The World Economic Forum estimates that these problems will lead to a loss to the global economy of US 16 trillion by 2030. And today, an estimated 300 million people experience disability associated with depression. As other causes of death among young people are reduced, deaths by suicide are emerging as the second most common cause of young people dying. The COVID-19 pandemic has heightened awareness of the experiences of mental health problems. Mental health care and support services everywhere are experiencing increased demand. Many people are experiencing loneliness, grief, sadness, worry, and profound uncertainty about what a future living with COVID means for well-being. There have been huge investments in increasing access to care through telehealth, subsidised consultations with a mental health professional, helplines. But we know that these are not used by most people, and that population-wide mental health promotion strategies are also needed. We need new ways of thinking and new ways of responding. Emerging technologies like AI thus have an extraordinary potential contribution to make to improve mental health at population level, as well as providing new ways of detecting and understanding problems and assisting with their treatment. And it is in this space of innovative solutions for serving the global community that Monash University and the Monash Data Futures Institute have a major role to play. Through the university's international profile, it has a huge record for innovation and collaboration, and it has long served the global community in seeking to address global challenges. The Monash Data Futures Institute, in fact, acts as the access point to Monash University's extensive network of researchers, educators, engineers and scientists in AI and the data sciences. It partners with industry, governments and non-government organisations at all levels to address the most pressing global and scientific challenges of our time, including in governance and policy, sustainable development, and of interest to us tonight, the health sciences. So I want to thank in particular and acknowledge Professor Joanna Batston, Director of the Monash Data Futures Institute, for inviting me to host and moderate today's event, but for her extraordinary leadership in this field. In today's panel, the Monash Data Futures Institute has brought together experts across the disciplines of public health, mental health, neurology, artificial intelligence, data science, and medical imaging to discuss some of the latest research on AI for diagnosis, prevention, and better treatment of mental and neurological disorders. After the presentations and the panel discussion, there will be an opportunity for questions and answers, and I would encourage you to think about putting these in the Q&A as we listen to the important material that we're going to be introduced to you tonight. The first speaker I'd like to introduce to you is Associate Professor Debbie Scott. Debbie is the strategic lead for the National Addiction and Mental Health Surveillance Unit at Turning Point, which is an Australian specialist addiction research and education centre. She's an expert in public health, but she has a particular interest in the use of data to inform policy and prevention strategies. She's going to talk to us now about a flagship project she's leading, the National Ambulance Surveillance System, a unique data set to inform suicide and self-harm prevention. Debbie.
Thanks so much, Jane. I'll just get my slides up here. And I'd also like to thank the organizers for asking me to speak here today. This is such a great opportunity to present the work of my team at the National Addiction and Mental Health Surveillance Unit and some of the work we do with the National Ambulance Surveillance System. So, get my slides to change. They're not going to do that. Okay, so before I start, I'd like to acknowledge Naomi Beard and Courtney Wilkinson, who helped me prepare these slides for the presentation today. The National Ambulance Surveillance Unit project actually began in Richmond, an inner city suburb of Melbourne in Victoria in the late 90s, in relation to rising heroin overdose deaths in that area. By 2012, we were providing data on all alcohol and drug-related attendances across Victoria to the Victorian Department of Health and Human Services. And in 2016, the Commonwealth Government asked us to do the same thing nationally. So we were providing data on alcohol and drug-related ambulance attendances to them. Most recently, in 2020, we were funded by the Australian Institute of Health and Welfare to provide national data on suicide, self-harm, and mental health-related ambulance attendances. These data help address gaps in other data sets. For example, delays in health and coronial data can take anywhere from 18 months to 3 years to be available. Our data can generally be available within 3 to 6 months, depending on the jurisdiction. Additionally, there are some populations that might be missed in other data collections. For example, acute harms where patients aren't transferred to hospital, they won't appear in hospital data sets, or those who might be missed or underrepresented in surveys, for example, the homeless or children under 12 years. Existing coding systems for some data are not granular enough to capture detailed information on some conditions. No other data sets capture information on suicidal ideation, and the current version of the International Classification of Diseases, which is a global statistical classification for admitted patients and death data, doesn't distinguish between non-suicidal injury and suicide attempt, or the details on specific substances are grouped together into some codes. For example, amphetamine, caffeine, and energy drinks all sit under the same ICD code for stimulants. Ambulance data also provide incident location, which allows us to map specific harms to an area, and then policy and interventions can be focused on that area as needed. Our data have been used to inform various public health measures, like the location of the medically supervised injecting center in Melbourne, and more recently, the National Suicide Monitoring Project at the AIHW. Our data are unique and innovative. We were lucky enough to receive one of 20 out of more than 2,000 applicants for an AI for Social Impact grant, and we were the only Australian recipients of that grant from around the world. And we've recently been named as a finalist in the Research Australia Bupa Data Innovation Awards. So these data have been proven to be really quite exciting and innovative. The data itself are based on clinical records that paramedics create when they treat patients. We specifically code them for alcohol and other drugs, suicide and self-harm, mental health, and for some jurisdictions for violence. The data are based on the written records of the paramedics and include their professional assessments, but also information they may glean from others on scene, for example, bystanders or family members of friends. We currently have agreement with all Australian state and territory-based ambulance service, with the exception of South Australia, who've agreed to provide us data once their systems move from paper to electronic-based records. Our team of data coders read and code as many as 60,000 records a month. I'll just clarify that I think the IT speak word for code in this context is annotate. So to step you through how we create the data, it starts with someone calling triple for an emergency. These calls are triaged according to severity and urgency, and the ambulances are dispatched accordingly. Once the paramedics arrive on scene, they assess the patient, stabilize them, and then either assess them as stable and able to be managed at home, or maybe see their GP or another medical practitioner, or they may transport them to hospital if they require further assessment or treatment. The assessment and treatment is carefully documented in their electronic patient care record, and that's digitally saved to the ambulance services. Each of the jurisdictions then de-identify those records and provide an extract to us at Turning Point via secure transfer. Our coders read each record and code or annotate the information to create our data, and it's exported to our STATA database, where our researchers and analysts analyze the data and provide the data to various stakeholders. For example, local, state, or Commonwealth government departments, including the Australian Institute of Health and Welfare, the Victorian Department of Health, the City of Melbourne, and most recently, the Victorian Transport Accident Commission. And they use the data to inform the design and implementation of policy and interventions. We don't ask anything extra of the paramedics outside of the normal work they do in documenting their patient care. And our only request from the ambulance services is to send us the electronic extracts that we code. This is important because it doesn't add to the burden of the paramedics in the field. However, their records are created in order to provide a record of care that has been provided for the patient, not for research purposes. There are a number of text boxes and other various flags in the ambulance data, but if we relied on those, depending on the jurisdiction, we'd miss a significant number of attendances that are associated with alcohol, mental health, or violence. By reading the clinical records, we can reliably capture this information. And you can see from this slide an indication of how many of these records we'd miss if we just relied on the tick boxes within the paramedic system. This isn't saying the paramedics miss it. Their clinical notes actually capture amazing detail in every record, but that information is held in the database in text. And trying to use textual analysis for these issues is fraught, as you can imagine. Aside from considering typos in the data, imagine all the terms that might be used for something that's alcohol related: drunk, drinking, beer, rum. It goes on. And it's different across different jurisdictions in Australia. And that would be the same for every substance that we try to capture information on. As I mentioned earlier, we were successful in applying for a Google.org grant to try to find a way to use natural language processing based on the 3 million existing lines of data that we have to try to automate some of this. And Professor Buntine will speak to some of this a bit later. He's got more of the details on the tech stuff. Some of the variables we code include patient demographics, clinical data like pulse and respiration rates, the time and date of the incident, what happened to the patient, as in whether they were transported, not transported, the patient past history, the geographic location of the incident, and then some contextual factors associated with the attendance, like homelessness, history of child protection, employment or financial risk stressors. We capture information on self-harm, both suicidal and non-suicidal harms, and ideation. This information includes information about the method that the patient has used and the geospatial coordinates for that incident. And just to give you an example of some of the data, this slide shows trends in Victorian suicide attempt and ideation since 2015 in both metro and regional Victoria. You can see a slight upward trend, particularly in metropolitan Melbourne. The purple line at the top is the metropolitan area and the yellow line at the bottom is the regional areas. So all those areas in Victoria outside of metropolitan Melbourne. When we capture information on mental health related attendances, we don't have a diagnosis for the present attendance because paramedics don't actually provide a definitive diagnosis. So we report on the current symptomology based on the knowledge of the paramedics. And we then report on the historical diagnoses that patients may self-report. So for example, we might have a patient care record that says that when they arrive on scene, 35-year-old woman presents with symptoms of anxiety, claims to have been hearing voices. And that information then allows us to code that the incident is associated with either psychosis or anxiety. And then the past mental health history provides us information on specific diagnoses. So the paramedics will carefully document that the patient has a history of suicide attempt or schizophrenia or depression. And we can report on both of these for each attendance. This slide shows some of the mental health related attendances, again, broken down by metropolitan and regional Victoria. And in both, we see a slight upward trend. It's increasing, but it's interesting for us. We're looking forward to being able to analyze these data and see what the impact of some of the lockdowns have been around metropolitan Victoria, particularly because Melbourne was locked down much harder than the regional areas. And it provides a bit of a contrast so we can compare the two groups and see what we see in differences across the different populations. Often people don't think of alcohol and drug-related issues as being mental health, but they are absolutely entwined. In fact, often the alcohol and drug misuse is a symptom of the underlying mental health issues or historical trauma. We report on a wide variety of substances and capture the information at the broad category. So we can capture information, for example, on opioid analgesics, but we can also report at the level of the specific drug, so GHB or heroin or methamphetamine. This gives a really granular perspective and is so helpful for policy and intervention design because we know exactly what we're dealing with. So I'll present some data on alcohol-related attendances. And again, this is broken down by metropolitan and regional areas. We have two variables that we capture in the data, one that says alcohol involved and one that's a subset of the alcohol involved called intox. So the light blue and yellow line are the alcohol involved and the purple and gray line show alcohol intox. The difference between the two is based on the clinical acumen of the paramedic. So in alcohol involved, we might find that a person has had a drink or two. There might be mention of alcohol in the attendance. The ambulance isn't necessarily called because of the alcohol consumption. It might be that, for example, the medical notes will note that they've been called to a 30-year-old woman who presents having fallen down the staircase after tripping over her cat, says she has had 2 glasses of wine with dinner. So that would be classified in the alcohol-related category. In the alcohol intox, what you might see noted in the clinical notes are something like, called to 30-year-old woman who fell downstairs, says she's been drinking since 9 o'clock this morning, has drunk half a bottle of vodka, 2 bottles of wine, presents with head injury, slurring speech, staggering, and altered levels of consciousness. So they've assessed her as being intoxicated, and we can safely code that as that within this. We also capture information on violence, and that information includes whether the person is the perpetrator or the victim. And by understanding who the perpetrator is, we can then classify whether the violence is associated with family or community violence. And we also break it down by whether the violence is physical, sexual, or threatened. This slide shows some work that we did recently looking at alcohol license outlets, so alcohol outlets, and family violence related ambulance attendances. And it's broken down by population and postcode across Victoria. Each of these 6 figures are a map of Victoria, and the darker the blue, the more we see an association between family violence and alcohol. And what we found in this study was that increasing numbers of alcohol license outlets increased the amount of family violence. So there was an association between family violence and the number of alcohol license outlets. And we can map it to the specific postcode. So we were able also to see that this association was stronger in the postcodes that had the most disadvantage across Victoria. This is really useful for people who do policy and intervention design, because they can really target the specific areas that need the most intervention and recognize what's going on in those to intervene effectively. In suicide-related research, it's important because we can identify hotspots. So for example, people who try to jump off cliffs will show up in our data, and we can target those interventions with things like changing the accessibility, making it harder for them to access that, or do like they've done on the San Francisco Golden Gate Bridge and put phone handsets in to encourage people to speak up and ask for help. Both of these have been proven to be really effective in suicide prevention. We also capture information on social risk factors. So you can see in terms of self-harm that half or slightly over half of people who have any sort of self-harm also have some sort of associated social risk factor. And the bottom half of the slide gives you an indication of what those might look like. Family problems appear across self-injury, suicide attempt, and suicidal ideation. And we also see things like the patient being in foster care or state care, or there's issues with chronic pain or sleeping problems. And these are all commonly associated with suicide, but you can imagine having these data allow us to target the intervention, because an intervention for suicide prevention around someone who has chronic pain is quite different to someone who's suffering financial or homelessness issues. Finally, this slide captures just how interwoven all of these issues are. If you try to only intervene in self-harm and don't address mental health or alcohol and drug issues or violence, you're missing a big piece of the puzzle. And if we look at this, we see that between January and June 2021, there were 217 ambulance attendances that involved alcohol and drug, mental health, and violence and self-harm. So it's really difficult to disentangle that. And if we don't intervene in all of these areas, we're likely not to be very effective. Additionally, our data are really useful because they serve as a built-in evaluation of policy and interventions, because we can track the changes over time at the national, the state, and the local government level. And that's why these data are so critical. Without clear evidence of numbers and the crossover between these, we wouldn't even know where to begin. So thanks for your time. This is my email address. If you have any questions, please feel free to reach out. And I'll stop sharing and hand it back to Jane.
Thank you very much indeed, Professor Scott, for a most enlightening presentation and such a clear demonstration of the value of large data analysed using sophisticated techniques to inform public policy and clinical practice. And I'm sure people will want to ask you questions about these, and they will have that opportunity later in this session. But we're going to move now to the panel discussion, and Professor Scott will be a member of the panel. But in addition, I'd like to introduce the other members of our panel. First of all, Professor Ray Bunteen. He's Professor in the Faculty of Information Technology at Monash University, and he was Foundation Director of the Master of Data Science and is now Director of the Machine Learning Group. Welcome, Professor Bunteen. Our next speaker is Professor Patrick Kwon. Patrick is Professor of Neurology in the Faculty of Medicine, Nursing and Health Sciences at Monash University, and he's Director of the Epilepsy Unit at the Alfred Hospital in Melbourne. Welcome, Professor Kwon. And the final panel member is Professor Meng Law. Meng is Professor and Director of Radiology at Alfred Health and Monash University. He joined Monash after being Director of Neuroradiology and holding diverse senior roles in neuroradiology at the University of Southern California Keck Medical Center in Los Angeles. So I'd like to ask each of our panel members to respond to a particular question in their areas of expertise, but please also continue to put your questions into the Q&A. First, Professor Bunteen, I wonder if I could ask you to talk to us about what AI can do now in mental health, what might it do in the future, but perhaps also tell us your thoughts about what it can't do.
Okay, thank you, Jane. So I think the first thing before I get going there is I have to point out that AI really is the tip of the iceberg. There's a lot of work that has to get done before AI can even get out of bed, so to speak. So we have a lot of different fields, whether it be physiology or medicine, telehealth, teletherapy, and effective computing, which is the gathering and analysis of data about people. And we really saw that with Debbie's talk, where she gave us the whole history of their data collection for the ambulance data.
Just hearing that there's a little interference, I just wonder if you could step back a little bit from your microphone. That might ease that. I'm so sorry to interrupt you. Please keep going. Much better. Thank you.
Yes.
Much better.
Apologies.
No problem.
So I was just saying that we saw the process of datafication, which is where you really do a proper job of gathering, collecting, engineering your data so it can be used. Massive effort. And we'll probably hear more of that from our other speakers. So what sort of data do we get? Well, there's facial, text, voice. There's all sorts of physiological data, pupils, gaze, heart, and we'll see even more sophisticated stuff as well. So what does AI do? What can AI do? So right now, AI is really acting, if you like, as an idiot savant. It's really brilliant at pattern recognition. So looking at an image, hearing a voice, reading some text, and giving us an interpretation. And that capability in the last 4 or 5 years has blown up with the advent of deep learning and a whole bunch of techniques there. But if you take a sequence of this pattern recognition, you can then actually do quite good sequential analysis. And we're starting to see that with chatbots. In fact, there is now a number of chatbots available for your smartphone. And AI-assisted chatbots is actually a very, there's massive funding from Wall Street in this area right now. So what AI isn't doing is really higher thought, more abstract thought, and that is where we're currently going. But I would like to point out that really the real problem is that an AI doesn't have lived experience. So it can't have empathy in any true sense. It doesn't have that experience that where it can understand what you're talking about and what you've been through. It can't understand the nuances. It can only learn from the data it's seen, which will be a very restricted part of your capability. Where is AI heading? What is it doing? Chatbots monitoring medical staff to see how they're coping with the details. Simulated training. You can use AI to produce a simulation that can help train up our nurses and healthcare professionals. But really, detection and monitoring are the big things that are happening right now, which I hope we'll hear more about from our other speakers. So I'll leave it at that, Jane. I hope that's helpful.
Thank you very much. A really comprehensive picture of what AI can do at the moment and what might be some of the potential for the future. I wonder if I could turn to you now, Patrick, and I know that one of your research areas is the application of AI models as clinical decision support tools. What do you think is possible at the moment and might be possible in the future in implementing AI models for this purpose?
Thank you, James. Jane, that's a really great question. And as a neurologist, I like to think that the brain is the most complex and important organ in our body. And with such a complex organ, the AI can really has a lot of promise and potential to improve the diagnostic and therapeutic interventions. And that's where a lot of the applications of AI have focused on is in analyzing the very complex physiological and other biomarkers. For instance, looking at EEG analysis and for Meng's expertise, looking at detailed and MRI, other neuroimaging modalities. And that really has a potential to streamline the an interpretation of these very complex data we collect from patients, which at the moment are manually analyzed and assessed by highly trained neurologists in further subspecialty, like myself or other colleagues in the field. And there's a lot of advances in that area in analyzing this diagnostic information, for instance, in epilepsy, in detecting or even predicting or forecasting whether someone's going to have a seizure, which will be tremendously helpful. What I've been very interested in is in taking one step further, is to say, rather than just like Professor Bunting just said, more AI in terms of just, rather than just leaving at the pattern recognition stage, can we take AI one step further to look into the future, even as an advisory system? And in this case, we are asking whether AI can be used to guide our treatment decision-making. And so one of the possibilities looking at longitudinal patient outcome data, how they respond to different types of intervention, and build models to then be able to predict which patient is going to respond to which particular intervention. And that will bring truly the personalized medicine concept into reality. That is not without risk and a lot of caveats. And for example, there's been a recent study published in Brain, which is one of the top journals in neuroscience, that applied an AI model to clinical trials of a new medication to treat epilepsy. and the authors were able to use clinical information and genomic information to predict whether a particular patient respond to that treatment. The problem is that how would you implement it in the future? Would the regulators then only approve a drug that is been that is only approve the drug for use in people who are predicted who is going to respond? Or in future trials, do you then only include patients predicted to respond to go into the trials? The advantage, of course, is to reduce the sample size and make the trials cheaper, but then it raises all sorts of clinical and ethical issues. The other problem with these kind of as a decision support tool is that many studies lack not just external validation, but most importantly, prospective validation. So these models have to be prospectively evaluated, just like any intervention, they should subject to randomized controlled trials. And I guess one of the questions very important that we are now grappling as well is the broader ethical issue or acceptance. How would a model, an AI like a deep learning black box model be accepted by the patients and the clinicians in choosing an intervention? Would that be preferred or rejected? I think that depends on how the model will be used. Is it going to replace clinician decision altogether, or purely used as a decision support tool where I guess the buck still stops with the clinician? And I think until these questions are solved, then I think we still may have some way to go. But there's a lot of effort into this, and we are working with our colleagues in the Department of Philosophy and in machine learning, trying to address these questions.
These are profoundly important questions, and thank you so much for explaining this in a way that non-experts can imagine and understand. But I wondered if you could just talk to us a little bit more about the ethics. I know it's an area you've thought about a lot, but the ethics of using these technologies and how your philosophy colleagues are working with you on these ethics and how they might be considered and addressed.
Yeah, it's I must say it's really a step outside my normal comfort zone, and in medical practice, we are, I think, still as a profession we're very risk aversive, and even more so for neurologists, I might say, than other specialties, because we still know the brain so little. There's still so much more to know. And with these kind of black box modeling, it is, I think, we need to tread very carefully, how a model can be accepted by the practicing clinicians and patients alike. And many models are also built on large data sets as the nature of the technology itself, the deep learning. And where do we find these big data sets? Often in rich countries, resource-rich countries. And if models developed in resource-rich countries, can they still be applicable to people living in less resourceful countries, the low and middle income countries? And so there is a risk that we will be discriminating, I think, against certain people in our society, in the world. And this would be directly against our medical ethos that we should be treating, everybody should have the equal chance to receive the best treatment. So, and I think this is sort of some of the issues that we're now working with our medical ethicist colleagues.
Thank you so much. And these questions of equity are going to be important ones we might return to in our broader discussion. But I'd like to turn now to Professor Law. And we know that you also have been engaged in these really important considerations about AI and access to it and affordability. But I wondered if you could begin perhaps by talking about what we're using AI for currently in medical imaging.
Yes, thank you, Jane. And this brings together some of what Ray has been speaking about, and also Debbie. I guess from a patient's point of view, in terms of mental health and brain abnormalities, we're certainly working on a number of AI models that can help, as Ray was alluding to, detection of abnormalities. For example, it's often quite difficult for a neurologist or a neuropsychiatrist to figure out if someone is really truly depressive or suicidal, or may have anxiety or PTSD. But there are sometimes fairly subtle imaging abnormalities that we're seeing on the research aspect that may be really invisible to the human eye. So I think using artificial intelligence to detect some of these more subtle abnormalities is something that we're doing. So as Ray was alluding to, detection of abnormalities, often some of these abnormalities, as I mentioned, may be invisible to the human eye. And more importantly, I think some of the abnormalities in neuroimaging can be very laborious work. So there's a project that Ray and I are working on, for example, in detecting multiple sclerosis lesions. So if a patient has multiple sclerosis, they often have many lesions in the brain, often 15, 20, 30 lesions. And for us to look at one MRI scan and then a follow-up MRI scan 6 months later can take up to an hour for a human radiologist to do this. Whereas Ray and I are in collaboration with another one of our colleagues, Dr. Chong, is figuring out how to develop an AI to do some of these more laborious work using artificial intelligence. And I think this brings me on to, not only what Debbie spoke about in terms of the impact of lockdowns and the pandemic has had globally on all of our mental health, but we have to remember that, there are issues not only in being able to use AI to detect some of these abnormalities in our patients, but remembering that lockdowns and the pandemic has obviously had a detrimental effect on our healthcare workers, so the nursing staff and doctors who are caring for you. So, something that I often would like to talk about is a comparison between going to see a doctor or a psychiatrist who is himself or herself, suffering from depression or anxiety from, prolonged lockdown, and then having the opportunity of seeing a psychiatrist or a doctor or a psychologist who has the opportunity to use AI to help with their management of a patient. So, if a doctor that you're seeing may not be able to look through the entire medical record and be able to assess you properly because they're thinking about something else that's happening at home, or perhaps depressed themselves, they may not be able to come up with an accurate diagnosis and then be able to manage a patient properly. So I think having AI assist healthcare workers, and there are many examples of how this can be helpful to us, from the diagnosis to the intervention to the management of patients, to the usage of, as Debbie was alluding to, natural language processing to look through vast amounts of medical data and medical electronic data to help us make these diagnoses. So I think there's no question that in the current environment, AI has many opportunities to help us and also to help you as patients.
Well, thank you so much. Again, another description that is comprehensible to the broad audience that are joining us tonight, including me. But I wondered if you could tell us, we know that consumer experiences, patient experiences are crucial to informing healthcare practice and healthcare research. Can you tell us anything about what consumers are telling you about this? Are they finding it a helpful technology, perhaps even an intimidating one? What are we learning from their perspectives?
Yes, thank you, Jan. That's a very important question because we're always obviously doing all of this to care for our patients and to care for our consumers. So, as Ray and others have been alluding to, AI in healthcare and AI in medical imaging in particular has been around for a number of years now. In fact, probably more than we can remember. So we can use AI for processing images that help with diagnosis. We can use AI for, as Ray was describing, detection of abnormalities. We can use AI for a lot of laborious menial tasks that might take a long time. And it's apparent that as physicians or as healthcare workers, we actually don't tell our patients and consumers that this technology is being utilized. And so we actually did a survey of patients coming to the Alfred Hospital who were sitting in the waiting room, and we asked, how many of you were actually aware that we're using artificial intelligence in healthcare and in the various settings that you've already heard of today. And in fact, up to 63%, or perhaps even more, patients that come to the hospital, come to see you in the community, are not aware that AI is already being used. So it falls upon us to, one, inform patients that we are using artificial intelligence, and because often consumers and patients think of AI as a black box, as the Terminator, as the robot that could do something that's beyond human control. I think we need to educate them that in fact we're using AI, and two, the AI is being used to complement and to empower human doctors and radiologists to help in their daily work. And then three, I guess the question is, do we need to actually obtain consent from our patients before we actually utilize this technology? I think the majority of patients are probably, if we're using it for their well-being and for their healthcare, are probably reasonably happy with it. And I think from the survey of our consumers, they tell us that they're reasonably happy that it's actually a human that's taking care of them, but it's being powered by AI. They become a little bit more uncomfortable, and certainly would be against the fact that if they knew that their healthcare was being entirely driven by AI. So I think they felt more comfortable if the physician or the doctor or the healthcare worker that was taking care of them was being helped by AI. So no question that I think as we move forward with advancing artificial intelligence in healthcare and using these technologies, we need to engage our consumers, engage our patients, and really inform them that this is what's helping. And in fact, it can only be good to tell them this so that we can improve their health.
Thank you very much. And again, an important point that we might return to, which is how do we ensure that people are being able to give informed consent to care that is drawing on these techniques. That really leads me, Debbie, to ask you another question. Consumer representation and education of AI in healthcare is lacking. Do people need a data broker? I was struck by this in your presentation, that a lot of data is being collected that people might not necessarily know is being collected from observations, from their own self-report, and then from how you put it together. So I'd be interested in your thoughts about ownership of these data, of the digital data, matters of consent. Meng has talked to us about, and your reflections on those.
So that's a really interesting question, and it's something we think about all the time with the data. When we use the data, we're very careful to consider, and all of my staff will tell you that we each recognize that each line of that data represents possibly the worst day in someone's life. So we treat it with that exact respect. The NHMRC has set up very clear guidelines for the collection of this kind of data, and we had to apply for specific consent to be given access to these data. So one of the things that we had to prove was that, first of all, that the general benefit to the population would outweigh any risk to anyone whose data we were receiving. And then second of all, that there was no reason to believe that people wouldn't be willing to provide that information if they were asked. So in surveillance systems, broadly across most healthcare systems, we collect these kinds of data. Hospital data is coded. When you hear on the radio that diabetes is up or deaths related to fractured femurs are up, that's based on data that's coded in hospital records, and it's collected the same way we do. So it's de-identified. We don't know who the person is in that record. We just know that that's the information. And that's the way it works across hospital data as well, and many other surveillance types. There's cancer surveillance and injury and a number of other different kinds of surveillance.
Well, one of the public goods, of course, is informing public policy and in informing potential ameliorative interventions. I wondered if you could talk a little about how your data is being used in those ways, or can potentially be used in those ways.
Yeah, the data go, so we provide the data to the Institute of Health and Welfare, first of all. That's one of the big, they're the big national organization that collect data across different sorts of health information. And they then use that data and make it available to government to direct policy and practice. We're involved in a lot of different committees with government and advisory committees, and we bring these data to those advisory committees. For instance, on COVID, the Parliament came to us asking for information on what does mental health look like in Victoria at the moment related to COVID. So we were able to break it down in quite a granular way for the government to look at. And depending on who's looking at the data, we can provide a little bit more information and allow them to see what areas were most at risk for mental health or suicide. And we do that in alcohol and drug. Our data have gone to inform, for instance, the Safe Script program here in Victoria, where prescribing patterns of medications are analyzed to see if there's areas that we should be paying special focus to for risk of addiction and things. Our data have informed which substances should be included in that. So does that answer your question?
Well, it does. And I was interested particularly in your very geographically specific data that you could show us where particular problems are more prevalent than others, and whether that had actually led to location-specific interventions to try and prevent or ameliorate these problems.
Yes, so our data were used to cite the first supervised injecting room in Melbourne. So by identifying that the place in Melbourne where the majority of overdose deaths related to heroin were occurring, and we could use our geospatial coordinates to identify that area, the government was able to say, well, this is the area where the biggest problem is, and we can target that problem. So that gives an example. It's also used for things like suicide prevention to identify hotspots where we can specifically target interventions, or also to identify populations. So we can break the data down and recognize that something we've noticed in our data, for instance, is that young women in COVID, we're seeing an increase in suicide attempt in women under 25 at the moment. So we're going to pull that apart and see where are they coming from, what's the story, and then government can then target interventions or work with practitioners in those areas to be on increased awareness and help and make sure that we address those concerns.
Thanks so much. And I was certainly struck in your presentation that you can do this almost in real time, not quite, but very close, so that it is particularly useful. And I think especially useful during the pandemic, when we know that as the changes occur, people's mental health is highly reactive to severity of restrictions, to the local intensity of a risk of infection that in the general population people are experiencing.
Yeah, and we can use it for things like the bushfires. After the bushfires, we can target that. And Ray can talk to how the Google grant that we've received for the natural language processing is going to bring increased efficiencies in the timeliness of the data, because it'll take us less time to code the data. So it'll make it more available more quickly. And Ray can talk to that better than I can.
Ray, would you like to take that point up and talk to us a bit about that?
Okay, so this is in fact quite a common problem that occurs across aspects of medicine. And in a sense, it's also related to Meng's problem with detecting anomalies in images, but for us, it's text. So what we're going to do, what they have is, say, 20 or so human coders or annotators who inspect the records and mark it up. We want to make their life easier. We want to take the easy records out of their hand and let them focus their time on the hard records. And so we use the machine learning technology, and in particular, the language modeling that has really blossomed in the last few years. We use the machine learning technology to filter. And what we want to do is pull out a large volume of records that we believe, that our system strongly believes, are not relevant. And you see, one thing we do that the algorithm has to be very good at is predict its own confidence. It has to know whether it has a strong belief that it's right about this particular record or whether it's uncertain. And the uncertain ones we want to pass on to the human experts to show their expertise. So this is the basic idea that I expect to see used throughout areas of medicine and mental health, where the machine learning is used to filter out the easy analysis and sort of give a recommendation and leave the hard analysis for the experts. Think of it as a power tool. I'll leave it at that. Yeah.
Well, I think it's very persuasive and compelling that, with scarce resources, this is the kind of thing that is enormously helpful in terms not only of healthcare expenditure, but as we were hearing earlier about precision and accuracy and predictive power that these technologies can bring us. I wondered, Meng, if I could ask you another question. You suggested, I think, in your response that it might be possible using AI to detect subtle differences in the brains of people experiencing either mild or moderate or severe mental health problems. This has certainly been an elusive goal in the many years in which I've been a practitioner. But I wondered if you could talk to us about whether AI might be able to detect early deterioration in the brain and what it is doing that might precede the actual expression of symptoms or altered behaviours.
Yeah, that's a great question, Jane. I think that's really the holy grail in diagnosis for, and Patrick can probably speak to this as well in terms of neurological diseases as well as neuropsychiatric disease and mental health issues. So, we now know that pathologically there are abnormalities in the brain, and there are probably abnormal blood biomarkers and biomarkers in our the fluid that surrounds the brain that can actually help with this diagnosis. And the issue is that the tools that we're using with MRI scans and CT scans are probably not currently adequate enough to demonstrate to the human eye these abnormalities. So if we kind of look down microscopically, so on a microscopic level, these pathologic abnormalities are in the brain. So they may be, differences in some of the biochemistry in the brain that might lead to depression, or some of the neuronal discharges in certain parts of the brain that might lead to PTSD or anxiety, for example. And so they're there and they exist, but the tools for us to demonstrate these are probably not sensitive enough for us to be able to see them in the human eye. But if we know that that's the gold standard and that's the pathology, we can use that gold standard and the pathology to actually tell an artificial intelligence model that the abnormality exists on the MRI scan. And even though the abnormality is invisible to the human eye, by using a gold standard like a pathology, like a microscopic slide to actually detect it on a scan, can then allow us to actually find these abnormalities and then make an early diagnosis. So to your question, I think it's possible. We're working very hard towards that, and many others around the world are also using this approach to try and make an early diagnosis of whether someone is potentially depressed or whether someone's potentially suicidal. There's still a lot of research that needs to be done, both on the clinical side, from Patrick and his team to demonstrate what some of the phenotypes are for various mental illnesses, and then the imaging, and then the blood biomarkers, and some of the clinical findings all need to be put together. And really, when you think about it, there's so much information that it's almost impossible for a human healthcare worker or human physician to then amalgamate and put all this information together to then come up with an accurate diagnosis. And this is where, as Ray was alluding to, there is so much information now that's being gathered. And so we really need to use computational powers and artificial intelligence to try and tease through all this information to help us with the diagnosis. It's almost impossible for a human physician or human doctor to do this.
Very helpful, thank you. Patrick, I wondered if I could turn to you now. We've had some terrific questions posed to the panel by participants in this webinar. And one of these from Tianu Robeck is, we use many algorithms in healthcare now, but there's not a great deal of regulation of them, and often we don't ask for specific consent to their use. Regulation of algorithms is embedded in complex medical equipment. I wondered if you could talk about how you think the TGA might contribute to this, or do you think we need an additional separate regulatory body?
Thanks, Jane. And then the person who asked the question, because I was just about to touch on this point. A lot of the issues that I think Meng raised about consent and how these AI models are used, I think really illustrate the situation where we're in, where I think regulations really lagging behind of the technology, as is often the case. Think of Uber. When it comes along, how disruptive it is. And in a way, I think we really need to think about, with different models, how the model is going to be applied. Ray mentioned about whether it should use as a screening tool to screen out the easy ones and then give the difficult ones to humans. Whereas Meng talked about using the AI, in fact, almost as a safety net to pick up things that the humans missed. So perhaps different models, we need to have a more sophisticated regulatory system to decide how each model can be used. And obviously that would have to be based on the evidence of its utility and validity. And that involves the whole process of how these models are developed in the first place, and which is, I think, would require a very different way to regulate compared to, say, just a drug or a particular device. What I said earlier on, in using AI model to even select the best treatment for a particular individual, that's when when databases become interventions. And how would you regulate that? And the TGA has recently released a document early this year about regulating AI models as a software, as a medical device, what they call. And in this case, the device is, there are now clearer guidelines on what constitute as a medical device and what constitute as a device that may need to be regulated, and those devices that can be exempt. And that's an important way forward. And I encourage those who would like to look into this more to go into the TGA website. On the other hand, the FDA, I think, is, as not often the case, a bit more advanced than us in this part of the world. And they have approved a number of AI-assisted models in healthcare. And as Meng alluded to, many of these relate to radiology. In my area, there are very, very few in neurological use. And so I think the regulatory landscape will change, it has to change. And I think clinicians like ourselves, practitioners and patients and the general public are key stakeholders, and we need to make our voice heard by the regulators so that on the one hand, we will not be in a situation where I think putting the onus on the patient to decide whether to give consent, and we have to ask the question whether the average patient will be able to do that. I think of the days of GM food. You think of, well, is there GM in my food? And later the regulators come on. We may be in that scenario. On the other hand, we don't want the regulators to deprive the benefits of AI, which can bring benefits not just to healthcare, but economic into the society as a whole. If we can move away from trial and error, tossing a coin in selecting the treatment, to a really personalized treatment that will, the patient will be targeting for that particular individual. So there is a balance there, and I think we have to be more active and to make our voice heard by the regulators and the policymakers.
Well, thank you very much. And I think we would want to add also by the consumers, by people who are experiencing the use of these technologies. We've got a specific question about that, but I wondered before we get to that, whether I could ask you, Ray, do you see democratization of health information coming to imaging anytime soon? This is happening in the genomics space from companies like 23andMe.
Yes, I've recently sort of encountered a similar thing myself, where I can actually go and request blood tests without even seeing a doctor. So I would expect fairly soon these services, appropriately regulated, would become more readily available. Do remember that most of these, whether it be an image or something, requires interpretation by a doctor. You cannot interpret yourself. And moreover, if there are serious issues discovered in the images or the blood tests, somebody has to act on that. So I think it can happen, but this has to be developed by the medical community, really, and together with appropriate technology people. But I'm pretty sure it'll be a thing in the future. And I know the Australian government is starting to collect all of our data on a central repository, so to speak, though that is only available in a very exclusive manner.
Thanks so much. I'm sure this is something that will change. Debbie, we have a question from Alison Johnson, and she's asked, do any of the panel members have a group of consumers that they ask for input into their ongoing AI projects? So a group that provide input over a period of time about different aspects of AI. And I wondered what your reflections were on that, including in relation to your own work about complex topics, alcohol and other drugs, violence, the need for ambulance and emergency services.
We do have a group of consumers that we work with, both around suicide data and around the alcohol and drug work that we do. Lived experience is a really important part of how we work in the suicide space and in the alcohol and drug space. But they're not so much involved in the AI project. This is so new to us, and we're using it just to set it up at the moment. So as we go, we will probably ask for their input to make sure that we're across everything. But really, what we're going to be doing with our data is just coding the data, helping to gain efficiencies in the coding. So it's probably less of an issue. We hear more about this kind of thing in things like where they use surveillance cameras around violence or even suicide prevention. There's been work done on rail platforms to look at the behaviors of people before they step in front of a train, for example. And AI has been used to actually be able to predict the behaviors and allow station masters to intervene before someone does. That has probably bigger implications, particularly for families where it's their loved one that's been involved, and I can understand that. So that kind of thing, I think, needs more input from people with lived experience. but as a public health practitioner, one of my principal beliefs is that overall, it's about public good. So these data really can go to make a difference to people. Those films, that information exists anyway. Why would we not use it to make a difference and stop someone else from doing a similar thing? So to me, it's really about the public good against the risk that someone else might be involved. And provided we can make sure that we're not risking identifying someone, then I think the public good really has to be taken into account.
Thank you. Meng, in your comment a little while ago, you remind us that mental health professionals, other professionals, all health professionals are affected by the pandemic. Many are experiencing significant stress or fatigue or worry themselves. So we have a question from one of our participants who has asked, how is burnout perceived? Is it a mental health disease? Are there any efforts ignited in the space of early burnout detection using AI methods, and what your thoughts are on that?
Yeah, I saw that question on the chat and I was hoping that someone else would answer that, Jane, but that's a very good question. And I think that, I was reading through Natasha Smallwood is a colleague of ours at Monash University. She's a respiratory physician. She'll be on ABC, I think in a week or two. And she's written quite a number of papers now on mental health in healthcare workers. And I think from her publications, I think she does describe burnout as a mental health problem in healthcare workers. And it's probably in the publications that I haven't had a chance to review properly, but I suspect that there are signs of burnout clinically, and Patrick maybe and others maybe will speak to that. I'm not aware myself personally of AI methods to be able to detect that early on, but I suspect that our frontline workers in the hospitals are certainly expressing to me when they're exhausted and when they have to come in and put on PPE and don and doff PPE every single day and every single COVID patient that they see. I'm sure the ambulance workers, who are out there and seeing patients are also burnt out and undergoing an element of fatigue. So I'm sure it's present. I wonder if others on the panel might be able to address, how we may be able to detect this, or whether there are early signs and symptoms that can help us detect these colleagues who are burnt out.
I could just mention briefly, there are a number of companies AI companies that are funded to detect burnout. It's quite a complex area, as you can imagine. Say trying to detect sarcasm in text is quite difficult. Well, burnout, it's a series of stages, and there's a number of things you have to be able to recognize. So I'll just say it's a very complex area. I wouldn't know how to do it, but I do know companies that are working on it. You've got to put it, because all companies, whether it be a truck driver or an office worker, have burnout problems. For certain places, it's more important. A medical worker, obviously, burnout is critical. But it's something you have to detect in their patterns of communication, all sorts of things. So, yeah, it's...
While you have the floor, Ray, we have a question directed to you. Do you think there might be downsides to the application of AI or natural language processing or chatbots? One of the concerns that the questioner has is the impacts on privacy. And I wondered if you could comment on that.
Yes. This is, of course, an issue that, well, I think you've already heard our medical colleagues, Meng and Patrick, refer to the privacy issue quite a bit already. And I'll tell you now, Scott's data is locked down tight. But the thing is that companies, usually under less constraints, most hospitals and government organisations have very strict privacy requirements that they must adhere to. Companies are under less constraints, and if they keep that data internally, then it's actually quite small what they're required to do, other than things like the GDPR that's in Europe. And if the company goes broke, oftentimes they may sell that data on, and that then creates a real problem. Clearly this is an area that's still in development. That's about all I can say. And there is a huge amount of data being collected. And the one we all know about is the search engine data, which pretty much exposes your religion, your political beliefs, just about everything about you usually can be estimated from your, with a 95% accuracy from your search data. So, but yes, privacy is an issue. It will require government intervention. That is slowly happening. And at least we know the governments and hospitals are really making a very good job here. And the companies are brought on side. Google, for instance, makes a huge effort. When I worked at Google, I knew that none of us could get access to search queries, not in a million years. It was very much locked down to a very small group. Google and such companies take privacy very seriously because they know that damage to their reputation if these things are broken. Yeah.
We have time perhaps for two, but I think at least for one more question from Mark Howard. And he reminds us that clinical encounters are essentially relational. They involve one person talking to another person about their health, their concerns, their worries, their aspirations. And he raises the question for us, is there a risk that AI will either disrupt this relationship, which is so therapeutic and so valuable to clinical outcomes, or will it be used in ways that enhance and strengthen that clinical relationship? Now, Meng, you have your hand up. Does that mean that you'd particularly like to tackle that question first?
I could answer that question, but I actually wanted to raise another question about that Ray raised in terms of data privacy. I think that Joanna Badstone and I have had many discussions about the fact that as patients and consumers, almost all of us are happy with our data being used for the clinical care, number one. And number two, probably also happy for all of our data to be used potentially for research. But the minute that data becomes the property of industry and becomes commercialized and monetized, that's an entirely different issue. And I think that's a major factor in terms of data governance and data privacy. So I think that's an important point to make. I didn't miss some of the question that you raised with Mark, but I think it from reading the question on the chat, it sounds as though it pertained to using AI to enhance our interhuman and interspecialist relationships. And I think that a lot of the times, we do probably spend too much time in our day-to-day tasks. And I think if AI allows us to spend a bit more time either amongst our colleagues or developing relations between our colleagues and between our patients, I think that's certainly a plus. I think that was a question that's being asked, but I'll have to defer to others, I guess, on the panel.
I know this is something Patrick thought about, so perhaps, Patrick, you might have a question, but do you have a response to this, the impact on clinical relationships of the technology?
Yeah, thanks. That's a great question for Mark. And in fact, with Mark, we are doing a project to look at stakeholder perspective on exactly on this aspect in making clinical decision. And we're lucky enough to have a seed grant from the Monash Data Futures Institute to look at this question together with an expert in consumer engagement. And I wanted to use this to address back to the previous question about engaging consumers. And it's true. I mean, we, if you say to a patient consumer, the algorithm will now see you. It doesn't have the same ring as the doctor will now see you, does it? So often just seeing a doctor itself can have a therapeutic effect on its own. So how would AI change that? And we like obviously to see that the AI will enhance that relationship, but there is a risk that it can disrupt that relationship. And I think that's exactly what we're working on with Mark and his colleagues in looking at this very sensitive, I think very delicate aspect, and with co-developing, looking at co-developing research outputs with people, lived experiences of their condition, having workshops with the patients and the clinicians separately, and then aiming to develop an ethical impact assessment in consultation with all the stakeholders. And I think that is a very important way if we want to really harness, I think, the power of AI in healthcare.
Thank you. I didn't realize that was an insider question, but I think it's incredibly crucial. And it's really a wonderful note for us to draw this webinar to a close on. I really want to thank all four of our speakers for illustrating for us this extraordinary frontier in which we've heard about AI and its potential to elucidate problems of public health concern, enable our policy to be informed by that up-to-date data about obdurate, complex social problems, about how it can assist us to begin to understand subtle changes in the brain that might not be detectable to a human observer, no matter how experienced, and how it can quite possibly obviate the need for humans to be involved in every test and examination, because AI has potential to do much of this work, perhaps with more precision and with less fatigue. And we've been reminded that we have to hold consumer experiences of these technologies very much in mind, and that there are ways that this is being done, but that the ethics of these technologies will continue to be an important shared responsibility and consideration. So thank you very much indeed to all our presenters. I think this has been tantalising, and that I'm sure many of us will want to return when there's an opportunity to hear what's happened over time, how these ideas have advanced, what the technologies are able to do in the future. So I wish you well, and it's time now to hand back to our colleague Ida in ITU to draw the seminar to a close.
Thank you very much, Jane, and a big thank you to the panelists as well as the participants for making this such an interesting and important discussion. We will now be opening a quick poll with just one question. Please answer and let us know how much you liked this session. We also encourage you to check out other AI for Good sessions online that may be of interest to you. So for example, next Wednesday, the 20th of October, we have two sessions, one on AI for environmental sustainability and a climate science session later that day. We are posting the links in the chat and encourage you to join. And of course, you can rewatch this session anytime on our AI for Good YouTube channel and share it with your friends and colleagues. With that, we have reached the end of this webinar, and we would like to thank once again everyone involved, our panel, our participants, partners, sponsors, and co-convener Switzerland. Thank you very much, and we hope to see you again soon.
Rewind selector. Rewind selector. Rewind selector. Rewind selector. Rewind selector. Rewind selector. selector. Rewind selector. Rewind selector. Rewind selector. Rewind selector. Rewind selector.